Mm, Thank you. Yes, Dr. Chia Liang or Dr. Ang, as I'm known in Singapore. So I think we've had three very excellent talks, certainly very complicated problems and issues shared by Dr. Endosek. And so just to round off the whole session, I just wanted to share some of the pointers which I've learned over the years. Of course, many of these has been covered, but just as a roundup. And so hopefully with some pointers, some more careful way of fixing calcaneal fractures, we can avoid some of the problems which we've just seen. So I do a lot of sports, joint replacements, but I do a fair number of trauma too. So let's go ahead and look at this. I think the importance of the calcaneal bone is well known here already by everyone who's attending this webinar. It's been observed more than 100 years ago that somebody who breaks his heel bone is done, can't work anymore, and certainly it's still the same sort of situation, the same case, even for nowadays. So as with any calcaneal injury, standard assessment, I won't really go into. Everybody knows how to do it. For example, things like mechanism of injury, the wounds, swelling, soft tissue condition. And for me, I always ask them whether they smoke. And then we go on to do x-rays, including lateral views, axial views, and Broden views. I do CT as needed if I think that it looks complicated, not the simple Sanders tool. So for simple Sanders tool, I don't CT. So sometimes I fix calcaneums without CTing them. At this point, I just want to share a little bit of what I learned from the literature. I think the truth is that it is still almost quite wide open. What is the optimal treatment for calcaneal fractures? There are many papers, tons of papers, and people have done meta-analysis, Cochrane reviews, and most of the conclusions really is nobody can really tell for sure what exactly is better. But I've picked a few which looked more relevant. So the first one is by Ning Wei and others. It's a meta-analysis, 2017. They find that surgical treatment of displaced intra-articular calcaneal fractures, certainly it restores anatomy better. And because it restores anatomy, there is less shoe wear problem and there's a higher return to work. But of course, because we operate, complications are higher. The second one, Cochrane review in 2013 by Bruce and Sutherland. Operative treatment has less likelihood of subsequent subtalar fusion because of less likelihood of arthritis. And also surgery can allow the patient's faster return to work. Again, it has higher complications. Last one I found, prospective multi-center RCT in 2013. At 1 year, they concluded that surgery is not superior in terms of pain, in terms of function, AOFAS scores. But in the medium to long term, surgery is associated with lower pain and less subtalar arthritis. So I think for the right patient, certainly there are some benefits to surgery. And so in my mind, the benefits or the goals of surgical fixation are mainly these three. First is to restore the subtalar joint, to reduce arthritis and pain in future. And so we're not looking at 1 or 2 years down the road. We are thinking about 10, 15 years down the road. And so that is something I will frequently help the patient to understand. It's not that it's not that we're saying that we can reduce pain 1 or 2 years later, but it really is something about his future. And we want to correct various alignment and reduce any lateral blowout. And really the goal of doing this certainly is to allow proper shoe wear. And of course, avoid all the complications and issues which we just saw just now. And while doing this, while fixing it surgically, we want to minimize complications like infection and wound healing problems. So let's just go ahead. I'll just show you some pointers which I've learned over this time. I think one of the things, well, different surgeons do it differently, but for me, how I put my C-arm over the years, I've come to put it just directly in line with the bed. So I put my patient on lateral position, and I use a sterile towel pack. I make sure it's a sterile towel pack, not a non-sterile pillow, so that it's easy to adjust the towel pack during surgery. I can move it away for the x-rays, and I can bolster it up for better support. So I bring my C-arm in with the base parallel to the bed at all times. And over time, I think this helps me. I don't have to think about where my C-arm should come in or figure out how to do the view. So to get a lateral shot, lateral view is easy. Just come in straight and you have lateral view there. There it is. To get an axial view, I will put my C-arm horizontal and I'll rotate the arm. So like this. I'll rotate the arm like this and dorsiflex the ankle, and that gives me a very good axial view, I find. And to get a Broden's view, same thing, the C-arm comes in line with the bed. So what I do here is that I will externally rotate the leg about 45 degrees. So this is effectively equivalent to internally rotating the ankle about 45 degrees relative to the C-arm. And then I'll put my C-arm at 10, 20, 30, 40 degrees as necessary to look at the subtalar articulation. So when I do an extensile lateral approach, just a few pointers which I just want to point out. I think we all know that we have to dissect full thickness flaps. I make sure that retractors, if any, are into the deep layer, into the periosteum. So I don't like them in the subcutaneous flap, the subcutaneous fat, for example. And when we close the skin, I always make sure we have to evert it properly. I don't accept any inverted skin closure. Sometimes if assistants close, they close it a little bit inverted. I redo them. Because when we invert the skin, we effectively reduce a lot of the surface area for subcutaneous healing. And most times I do it just in a double layer closure. And just by doing this, I find that, in my cases, I haven't had any infections with an extensile lateral approach. Sinus tarsi approach, I use an II to mark my incision. I make a cut like that. And I dissect subperiosteal, retract the peroneal tendons, usually inferiorly, and we should have a pretty good view of the subtalar articulation. So reduction, I do it just a little bit differently. Most surgeons or many surgeons will use a shunt pin in the posterior tuberosity. For me, I just use two mmK wires. I drive it through the calcaneum from lateral and it comes out medial. So I use it almost like a bicycle handlebars. And I use that to manipulate and pull the calcaneum out to length. Of course, we will need to use instruments within the fracture line itself to help pull out the calcaneum. Sometimes I put K wires too in the cuboid and do a sort of like traction. So I find that I don't really use like an external fixation device. Also because I tend to be able to get to them probably early enough within the first 7 days or even 14 days post injury. I think it's possible to reduce it like this. having pulled out the calcaneum to length, the next thing to do is posterior facet elevation. And I do this just by inserting a periosteal through the lateral wall fracture line and to push up the posterior facet. And I take care to preserve cancellous bone that is just beneath the articular surface. So I don't want to be pushing so much or pushing so forcefully that I push out all the cancellous bone. And this is important to make sure that there's still some cancellous bone that is just subarticular so that we can put our cannulated screw there. And I reduce the medialmost fragments first and check Boden's views. And so once I've reduced the posterior facet, I fix it just using cannulated screws with washers. I have used headless compression screws before, but I find that that's not a very good idea because if the day comes where you have to remove a headless compression screw, you will need II and you will definitely need to take off bone from the head, bone around the head of the screw, because bone is just going to grow all over the head of the screw. And then I align the posterior tuberosity and fix it to avoid any varus malalignment. And then the last step I do is what I myself call fragment-specific fixation. If there are fragments, if there are fracture lines in the posterior tuberosity, big enough and displaced, certainly we can consider fixing them. So we just look at some illustrations. And most of these cases nowadays, I do it MIS because I find that it works in my hands. It's enough to get a good subtalar reduction. And let's look at them. So this is Sanders tool with marked posterior facet depression, varus alignment, and through MIS sinus tarsi approach, you reduce the posterior facet and fix it with cannulated screws. Now the screws should look like they're going a little bit anterior, just something like that. And another case, I like my screws looking like this. They should look like they're going anterior and just look nicely parallel like that. So that's the best kind of look I like. Sometimes my screws look like this, but I think it suffices as long as it fixes through sufficient cancellous bone to support the articular surface. You don't want to be fixing a void here, in which case it doesn't do much at all. And axial views. So for this case here, this patient had a tongue-type posterior tuberosity fracture together with a fracture of the medial side of the posterior tuberosity. And I chose to fix it, just one screw each. And to fix this one here, it may not be as easy as it looks. And we may have to make, I had to make an incision on the medial side that's sizable, probably about 2 cm, to let me reduce this fragment and fix it with a cannulated screw. And my post-op regime, just to share a little bit, I make them non-weight bear, at least about 3 weeks, but then I'm fairly aggressive with weight bearing thereafter. So many cases, at 3 weeks, I will put them on an air walker boat, just like this, and they can start just light weight bearing with crutches. And I'll teach them to do passive range of motion and gentle wound massage, just even 5 days post-op. And this is because I find that a lot of post-op pain that persists for a couple of months, a lot of it is due to scar tissue formation, and especially in patients who find it difficult or are afraid to move their ankle, this is all the more important. So I encourage my patients to be active as soon as possible mobilize and bleed as soon as possible. And thank you. I hope this has helped round up this excellent session of talks, and I'll be happy to receive any questions if there are any.